Dr. David Siegel, thank you for being here. He's a founding director of the Institute of Myeloma, Hackensack Meridian Health Center for Discovery and Innovation. He's the chief of myeloma division at Hackensack University Medical Center in New Jersey. He had done such a magnificent work research-wise, pushing boundaries in the treatment of myeloma. Welcome, Dr. Siegel.
So before I start, I want to say that Maher picked this case and not me. So this is a 76-year-old man who presented, as do many myeloma patients, with hypercalcemia, with renal insufficiency, huge light chain numbers, bone marrow heavily involved. Went on to what is not our standard of care, but KCD rather than KRD, and then on to a melphalan transplant. We had a clinical trial that looked at consolidation with the combination of elotuzumab, pomalidomide, and dexamethasone. The patient had that and actually achieved a high-level response, better than a VGPR, but not a complete remission. He had not a particularly good durability response, had been transplanted in 2021, but was progressing already by the middle of 2022. Got daratumumab, carfilzomib, and dexamethasone, so I'm not against daratumumab, but was my patient, but that's besides the point. Again, did not have a particularly durable response, went on to a clinical trial using an XPO1 inhibitor called selinexor. I don't know how many people, but it's a nuclear poor inhibitor, and the feeling is that the mechanism of action is that it traps tumor suppressor proteins in the nucleus and overcomes some of the negative consequences of loss of tumor suppressor proteins, which myeloma is very good at getting rid of. Had a bone marrow that was done initially that was negative, but then, again, shortly thereafter showed a very rapid progression of disease with 40% marrow plasmacytosis. With the subsequent progression, the patient went back on a carfilzomib-containing regimen, this time with venetoclax. He has an 11-14 translocation, which Dr. Albertor, I assume, will tell us. But I think the point of this trial is this is one of those patients that you were describing who comes in, gets aggressive therapy, and blows through everything that we do. And why does this happen? And would we be better off detecting disease earlier in these kinds of patients because their progressions are so rapid when they occur, and the patient gets into trouble very quickly.
Please have a seat here.
I'm not sure that she's...
Sit on the other side. The reason I selected this case actually because it is the last talk of the day, and I like to be provocative enough, and just leave you today with thinking of out of the box. So my goal of this presentation actually to emphasize minimal residual disease using cell-free DNA and cell-free RNA rather than using bone marrows. But just getting back to the case, here, so we get the first sample was, at least we had, was in 2023. And that case actually showed very little disease actually because of the KRAS mutation there. And we detected clonality for IGH gene family 322, and for the family, the 133. Now, here's the data on that particular samples. So the most important part is that there is very little disease in this particular sample, practically defined by the KRAS mutation, here, and of course the other mutation, the TET2, they are not relevant. They are really CHIP, nothing really, and even the ABL1, the SMAC3, it could be part of the disease, but it could be also part of the CHIP. We cannot really tell, but the KRAS is really part of the disease. But looking at the clonality, as you can really see it here, at this time, practically we see more dominant of these families, but by itself, it really does not really call it as positive. This is all based on the peripheral blood cell-free DNA and RNA. So we extract DNA and RNA from the peripheral blood and we sequence it like this. And this is when the patient came in the relapse, as Dr. Siegel said, and we see the KRAS mutation, but this time at very high level, in addition to the IDH1 mutation and multiple other mutations, including multiple chromosomal abnormalities and so these actually the chromosomal abnormalities, as you can really see them here. But here is actually the in the granulocyte versus multiple myeloma fractions, and this is on the cells here. And you can really see, for example, the KRAS mutation at 40%. In the multiple myeloma fractions, it is only at 4.17. In the actually, it wasn't even detected in the DNA. Actually, not in the DNA. We don't detect that mutation in the granulocyte fractions. We see that mutation on the RNA here at higher level, as you can really see it here. The granulocyte RNA, most of these can be really classified as CHIP. The CD33 mutation is the germline mutations. We detect it on the RNA. Because it is RNA, you cannot really use the percentage for defining germline or not. But more importantly, I think you can really look at the clonality here. So definitely there's clonality for the heavy chain at 3-33 with very high level here on the RNA, and on the kappa, as you can really see it here, there is no clonality on the lambda. Then the patient goes again and comes back, and this is actually in the bone marrow. We collected samples practically at the same time. We tested the bone marrow and we tested the peripheral blood. So now I'm showing you the bone marrow sample in which you can really see these mutations, which we believe that they are part of the CHIP, but the KRAS mutation is detected at very low level, as you can really see it here. And at the same time, we see the clonality is detected in the bone marrow. So the KRAS here detected at actually, this is in the granulocytes. There was, in this particular sample, this marrow sample, we were unable to isolate CD138 because they were so few, we couldn't really sequence them, So, but we sequenced actually the granulocyte, and on the granulocyte, we found mutations in the KRAS. So that KRAS, which I showed you, is based on the granulocyte, not based on the on the multiple myeloma fraction because we couldn't isolate multiple myeloma fractions. There was no cells adequate for sequencing. But we see if we look at the clonality actually here, and the gene family which is relevant here is the 333. But because we detected this clone in the diagnostic sample, so definitely the 333 is part of the residual leukemias, and that really help, as well as the kappa, which is the 133, it is also part of the leukemia. So simply we can really detect the leukemia here because we know the history, we know what gene family is expressed in this. Now, at the same time, we analyzed the peripheral blood. As you can see, this is cell-free DNA and cell-free RNA. In this, we see all the mutations except for the KRAS mutation. But we can detect on the cell-free, the peripheral blood, not the bone marrow, we can really detect the clone as actually we've seen it before, which is the 333 here. And you can really see it here. It's the same clone, and 333, and as a matter of fact, it is detected at higher level. So for all practical purposes, you don't need to do the bone marrows. I can really detect it on the peripheral blood, and this is actually what we do for the liquid biopsy. So on the liquid biopsy, we quantify the mutant molecules per 1 ml of a plasma. So for all practical purposes, this is way more accurate than quantifying based on the variant allele frequency. In the liquid biopsy, we ask how many molecules per 1 ml of a plasma, and we see significant difference between the variant allele frequency versus what we see in as how many molecules. And the molecule will allow you to monitor the disease way more accurately. So here, actually comparing the samples from 2023 with the most recent sample as a liquid biopsy. And as you can see, the KRAS was detected at very low level in the liquid biopsy in 2023, but not detected in the liquid biopsies of today's samples. But definitely the clonality, we can really see it actually in the peripheral blood, but we cannot really detect the KRAS. Now, the discussion would be, is it possible we didn't detect it in the peripheral blood cell-free DNA because the bone marrow is more sensitive for detecting that mutations, or is it possible that mutation is in the granulocyte and has nothing to do with the multiple myelomas? So that's really a question that I cannot answer. Also, my inclination is that it is in the it is in the granulocyte and not necessarily in the multiple myeloma. In a situation like this, the multiple myeloma, when it is so low levels, is better really defined by the clone that it is expressed, which is similar to the clonoseq. But clonoseq, they look at the DNA, they don't look at the RNA. In multiple myeloma, because we look at the RNA, we believe we are way more sensitive than the clonoseq that look at the DNA. But so we actually developed I think we are the only lab in the country or in the world who use RNA for demonstrating clonalities as compared to DNA, because everybody focuses on the DNA. So we validated our assays by practically taking samples known for clonalities because they are lymphoid cells, and we took samples. We know they are negative for any clonality that's based on tissue samples as well as cellular samples. And as you can see here, we establish a cutoff point between the highest expressed clone versus the second expressed clones. We take a cutoff point of 10. So if we take a cutoff point of 10, which means like it has to be 10-fold higher, the highest expressed clone to the second expressed clone, that allow us to demonstrate clonalities. So that actually give us clonalities in 94% of the cases, and we prefer to be on the stringent side. But every case we look at it, and this is assuming we don't know the history, we don't know anything about that patient. But if we know the history of that patient, we can really detect at way more lower levels that clone, which would be way easier. But this is if we don't know the history of this patient, we take a cutoff point of 10 as demonstration of clonalities and no clonalities. Oops. So this is based on a huge number of B cell and T cells. We looked at the clonality, demonstrating clonalities in cell-free RNA. So again, this is a cell-free RNA. Here's, this is data based on liquid biopsies, taking 671 cases of normal or CHIP, 449 patients with, we know that they have B-cell disease, whether it is multiple myeloma or lymphoma, and 51 cases with T-cell diseases, 327 cases with myeloid, and 98 cases with solid tumors. And we looked at clonalities in these cases using the peripheral blood. And this is the data actually here, as you can really see it here. So if we look at the B-cell clonalities in normal individuals, as well as patients with CHIP, we detect clonality based on cell-free DNA, cell-free RNA in 5%. And that's practically consistent with the MLB, which is like monoclonal lymphocytosis has been described in normal individuals. So it is the same level. So it is quite possible it is real, Now, when it comes to the B cells, we detect the clonality in 27% of these cases, again, using this cutoff point, which is of 10, very stringent cutoff point. And again, these cases, we don't know their background or what the diagnostic clone. If we know the diagnostic clone, of course, all of them will be positive. But currently there's a concept which is driven by Stanford for detecting or monitoring lymphoid neoplasm by looking at the mutations in the circulation, and actually they say that they are more accurate than the clonoSEQs, which I believe that they are more sensitive. So in contrast, what we do, we look at mutations and clonalities. So we combine the two, which practically we are really combining the adaptive with Stanford approach, or now they are called Foresight, and we analyze for clonalities. And this is assuming we don't know what our sensitivity would be way more if we are going after a specific clone, but using the peripheral blood rather than the bone marrows. So as far as I know, all the studies done in multiple myeloma are based on bone marrows, and I'm working with Dr. Siegel. We're going to change that algorithms, and we're going to change the practice of medicine in multiple myelomas and try monitor patients based on peripheral blood rather than bone marrows that allow us to do it more frequently, and in my opinion, more accurately. Because, as you all know, in particular, multiple myeloma is patchy. So it depends on where you put your needle in the bone marrows, and that's really notorious about multiple myeloma as compared with the other diseases, Now, just to move on, here for T cell, actually also we see some clonalities here. And so we see some clonality in myeloid, for example, diseases. And as well as we see some clonality for the T cells here. My expectation, the myeloid include MDS, include AML, and all these things. Perhaps we need to go look back again at these cases. It's quite possible there is a significant immune component there, and this clonality that we are detecting might be clinically relevant, for these cases. But this is where we are going, and this is what we are really thinking about doing. And I want to stop here and opening it up for discussions and questions.